This week on the BackTable podcast.
Advanced cancer management used to really be primarily under the purview of Hem/Onc. And now the exciting thing is that it is now truly multidisciplinary. I mean, these are advanced state patients where, in the past it was more like, oh, this is a Hem/Onc issue. Like we can't really do any local therapies to kind of help improve outcomes, but that's totally changed, right? I want to really expand the armamentarium for my patients, right? Just help them live longer. I may not be able to cure many of these patients, but what can I do to consistently, just constantly improve on their progression-free survival with each new agent? And so I think it's a really exciting time to be in oncology now in all the fields, including Hem/Onc as well as IR. We get to kind of offer these really novel therapies to these patients with very advanced disease.
Welcome to the BackTable podcast. I'm Tyler Sandow, interventional radiologist in New Orleans. It's a special privilege for me to be able to record this podcast. I have Dr. Sunandana Chandra, medical oncologist at Northwestern, and the godfather of Y90 and basically all of interventional oncology, Dr. Riad Salem from Northwestern. If you guys could do a quick introduction, I know I said your names, but tell me about yourself and what your practice is like.
Sure, I'm happy to start. Thanks, Tyler. I'm Sunandana. I am a medical oncologist here at Northwestern. I'm also the medical director of melanoma and cutaneous oncology. So as my role here at our institution, I both see a lot of standard of care patients as well as a lot of clinical trial patients.
And my name is Riad Salem. I appreciate the invitation. Tyler, always an honor to be doing work with Sue. My areas of interest have been in interventional oncology from a career perspective, mostly focused on liver and some extrahepatic disease, but it's really a pleasure and an honor now to sort of expand that role, particularly as an interventional radiologist, and work with Sue now in a more formal capacity on patients with metastatic melanoma. Obviously, their field has advanced significantly, and now the role of interventional radiology is going to increase as part of sort of the comprehensive service that we provide to take care of cancer patients and work with our oncology colleagues.
Now, Dr. Chandra, I Googled you before we did this. I obviously know Riad well because there's never an IR meeting that he's not on the podium for. But I Googled you before this because I was trying to delve into your practice a little bit. You are responsible for a lot of clinical trials, oncology clinical trials at Northwestern. Is that correct?
Yes, that's correct.
Awesome. So specific to melanoma, because we're going to dive down this route, can you give me a brief overview, global landscape of what melanoma is like, incidence, trends, survival, things like that?
Of course. So when we speak about melanoma, we're usually referring to cutaneous melanoma. There are some other rare subtypes, but for the vast majority, when one talks about melanoma, it's usually the cutaneous subtype. That's the most common. It's about 100,000 cases in the United States per year, and about 5% of them are diagnosed with de novo stage 4 metastatic melanoma at time of diagnosis. And so, in general, over the years, we've made a lot of advances. And by we, I mean, the medical as well as the scientific community. In the past, melanoma was treated really with chemotherapy. The progression-free survival were, days to weeks. There was no durable benefit. And for, the vast majority, if not all cases, it was 100% lethal in the stage 4 setting. Since 2011, with the advent of the first immunotherapy drug that was approved in cancer, happened to be in melanoma at that time, the anti-CTLA-4 antibody ipilimumab, and then subsequently nivolumab anti-PD-1 and other anti-PD-1 antibodies such as pembrolizumab, et cetera, have really changed the landscape of how we treat these patients with advanced melanoma and how well they do. So, the landmark CheckMate 067 trial, for example, randomized patients to 2 drugs with anti-CTLA-4, anti-PD-1 versus anti-PD-1 plus a placebo versus anti-CTLA-4 plus a placebo. So it was a well-designed, double-blinded, randomized trial. And in a nutshell, it showed those patients who received some sort of PD-1-based regimen, with or without CTLA-4, had not only an excellent response to their tumors in terms of shrinkage, but they had a durable survival. And in fact, of those patients who received both anti-PD-1 and CTLA-4, 1 in 2 of them are still alive 7.5 to 10 years later. So these are therapies that have absolutely revolutionized how our patients do.
Well, that's really cool. And I can't wait to delve down this pathway a little bit. So you highlighted one of the most important things. Immunotherapy really kind of started its game in melanoma, right? So now on the IR side, we're starting to hear about it. It came into our world more on the HCC side, but as we integrate more collaboratively with our oncologists, we have to know about these immunotherapy regimens. So cutaneous melanoma, non-metastatic, seems like there's a certain pathway for it, and I'm sure there is for the metastatic. Because we start to integrate more on the metastatic pathway, can you kind of describe what the standard treatment regimen would be for somebody that presented with metastatic melanoma?
Absolutely. So for a patient with advanced metastatic melanoma that's unresectable, usually we have 2 paradigms of treatment. The more common, I would say, is some sort of immunobased treatment. So some sort of immunotherapy, likely with PD-1 as the backbone. And then it could be PD-1 alone or PD-1 with another T-cell target. That's one paradigm. The other paradigm is only available for about 50% of advanced melanoma patients who happen to have a BRAF mutation. So those who have a BRAF mutation, you could actually use a BRAF and MEK kinase inhibitor. So these are oral drugs. These are pills that they could take. And so you also have that paradigm of therapy. Now, there have been trials, such as the DREAMseq trial, that randomized BRAF mutated melanoma patients to either arm, either immunotherapy or targeted therapy. And in a nutshell, it showed patients who were randomized to immunotherapy first had better outcomes and significantly better survival outcomes.
So you obviously know what you're talking about with this, and you were talking to a guy from South Louisiana, and I like to say we are 50th in everything. And so would you mind dumbing this down for someone like myself? Can you give me kind of the South Louisiana or layperson explanation for how immunotherapy works?
Absolutely. Well, so our immune cells, specifically our T cells, the way I explain it to patients is those are like the soldier cells. In the world of immunotherapy, T cells have been one of our main targets. So in a natural cancer immunity cycle, what happens is a person's own innate immune system, including macrophages, natural killer cells, etc., indiscriminately kill cancer. Those neoantigens are then spilled out into the periphery. They are then essentially picked up by antigen-presenting cells, which then present them to a T cell in the lymph node. That is more of an antigen-dependent mechanism, as opposed to with natural killer cells and macrophages, that's antigen-independent. So once those antigen-presenting cells present those melanoma neoantigens to a T cell, those T cells are then kind of learn and become primed to identify specific neoantigens. And then those T cells go out into the periphery, go back into the tumor microenvironment, and based on their learning and their priming, they find melanoma cells that have those neoantigens, and then they can cause melanoma cell death. What we call, a fancy way of calling that is an anti-tumor immune response. So in the natural process, that's how this anti-tumor immune response works. However, our bodies have natural checkpoint blockades built in because, too much T cell activation is going to cause rampant autoimmunity. So perhaps evolutionarily, these T cells can be blocked so there isn't autoimmunity, right? So what happens is these inhibitory receptors on the T cell are expressed. They bind their ligands, and the T cell shuts down. So in the world of autoimmunity, that's great, but in the world of cancer, that's not so great. We want those T cells to remain active. And so all these immunotherapy drugs that we've talked about, these are monoclonal antibodies that bind these inhibitory receptors on the T cell, preventing those receptors from binding their ligands and thereby keeping the T cell active. So in a nutshell, that's how they work.
I get it now. I love it. Thank you. So now we get patients that have metastatic melanoma and they get put on an immunotherapy regimen. How well does it work? What are the trends in progression-free survival and overall survival? How does that look?
Compared to chemotherapy that had single-digit response rates, with immunotherapy, especially combination anti-CTLA-4 and anti-PD-1 antibodies, the response rates can be as high as almost 60%, and they can be durable. We have median overall survival responses now of about 72 months in that CheckMate 067 trial. That tells you that these patients are living potentially for years with a complete response with respect to their melanoma. So the numbers look quite promising with respect to outcomes. However, in general, about 50% of our patients either have primary resistance to immunotherapy, that means they never respond to begin with, or they acquire what we call a secondary resistance, that they initially responded and then they no longer respond to immunotherapy. That's about 50% of our patients. And so for that 50% of our patients, we need other therapy. So these are PD-1 refractory patients, usually, is what we call them. And we need other therapies to be able to offer that subset of patients.
That's a good segue into my next question, which I haven't picked on Riad yet, and I promise I'm going to do it eventually. And I'm sorry that I'm picking on you, Dr. Chandra. So when someone progresses, right, we know there's going to be people that do great, and that's a 72-month survival benefit. For the patients that don't respond well, what do we do next? How do things look for those patients?
It's a great question. So for those of them who've had a BRAF mutation that we've already established, we could offer them the BRAF MEK inhibitors, which are targeted therapies. These are just pills. But again, that's only 50% of patients that harbor that BRAF mutation in their tumor. So for the remaining 50% of patients that do not have the BRAF mutation, we have to think about other options. First of all, we have to think about other T cell inhibitor targets, such as, we've talked about anti-PD-1, anti-CTLA-4. There's a newer one, relatively speaking, called anti-LAG-3. So we would think about those types of combinations. And then we would potentially think about a cellular therapy. It's called tumor-infiltrating lymphocytes, which is a pretty resource-intensive and a tough therapy option. And it can be also quite taxing for the patient because their melanoma tumor has to be harvested. T cells have to be extracted and grown in a lab. A month or 2 months later, those T cells can be reinfused into the patient. So that's another option that can be thought of. And then you can also think of clinical trial options, including oncolytic virus options, where you then inject these agents directly into the melanoma. So depending on the patient, their comorbidities, how they're looking, what you think that they can potentially tolerate, you have to think of the next option quite thoughtfully.
Thank you for also segueing right into this. I appreciate it. I promise this was not coordinated, but this is awesome. Thank you. So you talked about intratumoral oncolytics, and this is a talk on, we're eventually going to go down the segue of Replimune, but I am interested. So the trial that showed promise in the realm of metastatic melanoma was IGNITE. Would you mind talking me through that one from an oncologist perspective? Just a brief, quick hit overview on that one.
Absolutely. So the IGNITE trial, it was a phase 1/2 trial in which 140 patients with advanced unresectable melanoma, either advanced stage 3 or stage 4 melanoma that was unresectable, were treated with an oncolytic virus called RP1 plus nivolumab, which is an anti-PD-1 antibody. And the criteria for inclusion is that they've had to have prior PD-1 based therapy for at least 8 weeks, and they had to have progressed on that therapy. So these are pretty high risk patients. The biology of their melanoma having not responded to to some of the best therapies that we have, suggests that they potentially may not do as well. And so for that patient population to then be treated with RP1 and nivolumab, which is, again, an intratumoral oncolytic virus plus an anti-PD-1, then show an objective response rate of about 33% in this refractory patient population that never responded to immunotherapy was really quite remarkable. It was an objective response rate that I think we were all quite very pleasantly surprised with and are very excited about. And based on that phase 1, phase 2 study, we are now going to enroll patients into a confirmatory phase 3 trial that is currently ongoing, and we also have here at Northwestern. And, the safety profile with PD-1 immunotherapy is fairly well established. I would say in general tolerated by patients. Really the question was what did RP1 add to that safety profile? And in general, I think RP1, I would say, is quite well tolerated. There's a lot of constitutional symptoms that can occur, fevers, chills, rigors, perhaps some mild nausea, etc. But not only are they quite manageable, their grade or their severity is quite low. And then over time, as the patients get more and more injections, those symptoms do seem to dissipate.
That's cool. I want to highlight some things that you said. So first off, these are patients, like we talked about, that are kind of the poor prognosis patients, right? These are the ones that progressed on immunotherapy. And so they're going to fall down a pathway of either more aggressive lines, more aggressive treatment regimens, or trial of this. And then we live in the interventional oncology world where we talk about a lot of local regional therapy. And whenever we hear Riad up on the podium and he talks about his response rates for local regional therapy, Y90, they're like close to 100%. The man doesn't miss for some reason. He's awesome. But I think we got to make sure that when we talk about a 30% objective response rate, we're putting it in the context of systemic treatment, right? So on the IR side, while a 30% response rate doesn't sound good from a local regional perspective, from a systemic perspective, in patients that have had that progression on what would be standard of care regimens, 30% is actually quite impressive. And I think there were maybe 13% of patients had a complete response. It was around that 13 or 14.
15%.
Right? 15. Okay, good. I knew. Thank you. And so we had patients that all of a sudden demonstrate a great response. So we've turned the corner on patients that have, or I should say this therapy has turned the corner on patients that probably didn't have a good shot before.
Absolutely. And one other thing, Tyler, if I may add, is that the very cool thing about RP1 actually is that not only can you see shrinkage in the lesions that Riad would inject, but you would also see shrinkage in non-injected tumors, which is always like the holy grail, like this notion of, abscopal effects we're always trying to kind of demonstrate, but we rarely are able to. And yet with this oncolytic viral platform, we actually have established that these abscopal effects can happen. These distant, uninjected lesions can also shrink. So to your earlier point, we see a true systemic benefit these drugs.
It's very impressive. And I think also the other point to highlight is the adverse event rate was very, very low. You alluded to this, right? So it's not like you're torturing a patient by adding this therapy in. It's very well tolerated. So clearly there's a benefit here. Now, can you give me another South Louisiana basic layperson overview of how RP1 or intratumoral oncolytics work?
So intratumoral oncolytics, basically, the oncolytic viruses that we've really studied the most in melanoma, including RP1, is a modified herpes simplex 1 virus that has been modified to be able to kill melanoma cells when injected, but the risk of the person getting herpes is minimal to almost zero. So what happens is once this oncolytic virus is injected, it not only causes melanoma cell lysis, but it also is engineered to release a local GM-CSF, which causes a very inflammatory local milieu, which then attracts immune cells. And that then further augments that anti-tumor immune response. And so in general, that's how these oncolytic viruses work.
That's awesome. Thank you again for dumbing it down for me. Now I have tortured you so much, I'm going to turn you free, and I'm going to harass Riad for a little while. So let's talk about how we do this in practice. In that IGNITE trial, 60% of patients had visceral-only disease, 20% had cutaneous only, and 20% had mixed cutaneous and visceral disease. And so clearly, Riad, y'all do this, y'all are good at this. How does it work in practice at Northwestern?
Yeah, so let me first start by sort of adding to what Sue has been saying, and maybe setting the stage for the IR's role, if I may, Tyler. I think it's very short-sighted for interventional radiology to think that this is just a simple injection and it's not the most sophisticated procedures that we do. I think it's very short-sighted, and frankly, we're here to take care of patients. And these are patients that, to Sue's point, have progressed on everything else. So it's really incumbent upon us to do everything we can to help these patients, particularly when there are new, innovative, and really sort of groundbreaking results that are seen. So that's the first thing, that everybody has to be level set from that perspective. The second thing I would say is, as an interventional oncologist, if you're going to be involved in interventional oncology, one of our jobs is to do all of the work, the advanced cases, the simple cases, and to broaden our collaborations with oncology. Not, this is too simple for me, I only want to do the complex work. And so I think, again, this really provides an opportunity to collaborate in a new manner. I mean, I've worked with Sue for a long time, but now with the advent of this kind of treatment, it's even more intimate work and even closer work. And I think all of us really like that. I certainly like that. I know Bobby likes that as well. So I think it really solidifies that relationship. The novelty to this treatment is not the procedure. It is the process and the collaboration and the ultimate, benefit that you're going to paint to the patient. So the reality is, how does it work? Sue's got patients that she sees. Some of them are, superficial lesions that her and her team can inject. Maybe some surgeons are doing as well. And once things are more involved, then that in general will involve a phone call. Now, what I would say, before I go into sort of deeper detail is, I think every center will develop their own algorithm. What works best for you? Because there may be some economies of scale that are present in one center that aren't present at another. But every center is going to develop. And so what I'm discussing here is sort of how we tend to do things. We still need to learn more and fine-tune more, and other centers will do that as well. So once you've identified a lesion, then there's a lot of things to think about. If Sue's got a patient and she calls me and she's like, Riad, there are 3 lung lesions, 1 anterior mediastinal lesion, 3 liver lesions, 4 abdominal lymph nodes. Well, what's the easiest thing for me to do? Do I need ultrasound or CT guidance? Do I want to incur pneumothorax risk unnecessarily if I don't have to? Are those lymph nodes in the abdomen available and accessible? Is that mediastinal lesion too risky to risk sort of a bleed of some sort? And so really the first thing is to look at the entirety of the disease process as to how I can help Sue and her patient. There are algorithms that Replimune has put together in terms of how much of the material you want to inject, a totality. I think it's 10 is the number, 10 cc's. But we're going to be working together with Replimune to develop sort of algorithms as to where you want to distribute the material optimally. I know we'll probably talk about that a little bit later on. But if there are 3 or 4 nice abdominal lesions that I can get to with a needle, I may start with that. There are some discussions that maybe there's some benefit of doing at least 1 liver lesion because of the tumor microenvironment, the immunotherapeutic component of it. Who knows? Maybe there's only lung lesions, and so now you need a CT scanner, and now there's a pneumothorax risk. So the management, and so really, the initial conversation you have with Sue and your partner really sets the stage. If there's only lung lesions, I need a CT scanner slot. I need to follow the patient, get some chest x-rays before I discharge them. And what does discharge mean? Discharge usually for you and I, Tyler, means your discharge follow with your doctor. Well, in some cases, you may be getting your Nevo on the same day. You may be getting something else on the same day. So it's actually it's sort of a process-based relationship that you embark on to really sort of streamline things for the patient. So now, Sue and I have discussed, we've identified the lesion I'm going to inject. is the patient getting systemic therapy before or after IR, right? That's a process that places can decide on. If I've punctured the lung or the liver, the follow-up or the recovery is distinctly different. If it's ultrasound and superficial, I don't need sedation. So now sedation is not something you need to worry about. The patient can go to systemic therapy much faster. All of these things are important. Now, which lesions do I pick? Well, I need to document the lesions. I need to document them on my ultrasound or my CT. They got to go to PACS. Then we have to have a plan. Who's doing the procedure in treatment 2? Is it me? Is it somebody else? How am I documenting what treatment 2 will look like? And if we want to make sure that we sort of distribute the location where we are injecting the material, then how am I going to document that and relay that information so that my partner in 4 weeks, 6 weeks, 2 weeks, whatever the timing may be, knows that Riad has already treated these 3 spots and the next treatment are these next 3 spots. So these are all very simple, but very important to really optimize, how we're going to manage these patients. And so I start with that just to give you a broad base of things that we think about when we treat these patients, because the documentation is important and making sure that we do what's best from a protocol perspective and from a replicating of the clinical trial approach is going to be very important. So there are a lot of things. These are all simple for IRs, but it's a process that you have to embark on. And that's part of your role as an interventional oncologist, when you're working with oncologists like Dr. Chandra and other oncologists.
I think it was great. I appreciate the call to arms, right? Because I think it's important for us to understand that you don't just get to pass over what's going to, I guess you would allude to as a simple injection, right? I wouldn't compare this as, it's not going to be as difficult as a PVR tips, but it's something that anyone can and should be able to do, right? If you can do a biopsy, you can do an injection. And so I appreciate the call to arms. One thing to highlight before we dive down some questions specific to you is you really emphasized collaboration. And obviously Northwestern has been very, very successful because you have people that want to integrate across the system. You have medical oncologists that want to integrate with interventional radiologists and interventional radiologists who want to do the same, and then surgical oncology ahead. Y'all have been incredibly successful because of the collegial and collaborative nature when it comes to taking care of patients. And I think that's where we sometimes in the community, and I don't want to speak for everybody, but we sometimes wonder that if we collaborate too much, that we'll lose patients in one arm or the other, right? Like if I start to have people go see my medical oncologist before I do a treatment, I'm not going to be able to treat the patient, and which is a selfish mindset. But whenever you integrate with your oncologist, I think what people fail to appreciate is it's a rising tide rises all boats, and everybody benefits. The patient, most importantly, the patient. But when we approach things from a team and system-based effort, we stand to gain so much more. You wind up doing way more things in practice. And I think when people talk about how do I build my oncology practice, I hear this from time to time. The trick is you integrate as much as possible. You communicate as much as possible.
Yeah. And just to add to that, the patient is at the center. We practitioners, collaborators, we encircle the patient to do what's best for that patient. And that's really the way we should be looking at this. We want to get the optimal outcome, and everything sort of revolves around, what we do with that patient.
So the way that I see this and the way that you describe it, Sue calls you. She says, I have a patient that would benefit from Replimune. You look at the scan and you determine what are your first initial targets. And do you pay? So I guess there's an algorithm for how you inject Replimune. You can inject up to, 10 mLs?
10, yeah.
And it's based on lesion size, correct?
Yes, there's a soft algorithm that tells you sort of what to do with lesion size, and then the technique part kicks in, right? Like, what do you do with those 10 cc's? Maybe we'll talk about it at some point.
That's what I was going to ask. So now, let's say you have visceral disease, abdominal disease, stuff in the liver, stuff in maybe some iliac lymph nodes, stuff that's going to need some type of image guidance to inject. How do you tackle that? What is your thought process whenever you see a patient like that?
So I want to do the simplest, fastest, safest thing for the patient. But I also want to be respectful of process and respectful of what was done in the trial. It is very possible, and I have to look at some of the data, that there's an intent to get some liver injections done, for example, if possible, and not just lymph nodes. And so if I see a distribution, let me keep it sort of simple, of say abdominal territory and say liver, then I may use that 10 cc and inject a few of the lymph nodes and probably a liver lesion, just to distribute and keep sort of within the guiding principles of the trial. If I'm forced to, then we will go to lung, because lung, as you can imagine, is a different entity, different image guidance, different follow-up, different complication rate. Why, in an asymptomatic patient waiting to get therapy, would I take a 2, 3%, 4% pneumothorax rate? Why would I do that? I'm just embedding unnecessary delays in the treatment. So I will do that. And then what I have to do, Tyler, is then document it. I've given 3 cc's here, 3 cc's there, 4 cc's there, and I have to document. One of the things that we're going to work with Replimune, again, is to create various algorithms to maybe highlight the more academic centers, the large community centers, the smaller community centers, because, again, we want to make sure from an IR perspective, this is available everywhere. This is not some hyper-specialized procedure that can only be done in the large volume centers, like some of the complex stuff that we do. This is something that can clearly be democratized and socialized across many places. So we will build these algorithms to cover each of these places, keeping in mind sort of their internal limitations. Some places, the IR is doing many, many things. So we want to be respectful of that. But now we have to document that. Now I have to document that this is what I've done. And I've agreed with Sue that on treatment 2, I'm now going to treat this lesion, and that lesion. Right. And so there's a plan. And then there's some concepts of, recycling some of the easy lesions. Personally, when we think about the algorithms, and it's going to be based on what the data shows, the subset analyses of what was injected where as part of the trial. If I don't have to puncture a lung unnecessarily, why am I going to do that? Hemoptysis, pneumothorax, etc. Why am I going to do that? So we will be respectful of how the trial was executed, but we want to be practical and safe as well. So all of these things come into play, and I want to set a treatment plan for the next 2 or 3 injections based on for example, a form that we'll have that will sort of draw out where the lesions are. This is going to be treatment 1, treatment 2, treatment 3. It'll be part of the permanent medical record. So all of these things are the things that we're thinking about to make it easy for the interventionalists and to minimize the number of communications. Sue doesn't want me to call her 3 times, nor does she want my partner to call her. We've had a conversation for an hour. Let's be efficient and let's do it that way. The last thing I would say is I've always been a fan of hyper documentation in my procedural note, particularly when there's a plan. And I sort of devised this when I was early in my Y90 experience, development, and I would always have a very detailed plan such that my partner would know what to do. This is a selective infusion of this. Best way to see the takeoff of that vessel is the RAO 35 degrees. The Cobra does not work in this example because it's a very downgoing celiac. You need a reverse curve catheter. So I would spell it out so that my partner, if I'm not here, and in that case was Dr. Lewandowski, as you know, knows exactly what to do, and vice versa. So I can envision, and I do in these types of reports, I hyper document. This was treatment 1. I treated lesions 1, 2, 3 on the chart. In 2 weeks, we're going to treat lesion 4, 5, 6, etc. So make it easy, minimize sort of the challenges. And once you've gone through a couple of cases, I think it's smooth sailing from there.
You sound like Juan with the hyper documentation. Juan Jimenez, my partner. So yeah, I feel you, and I think I totally agree with you. I think it doesn't hurt to be as specific as possible. So you alluded to this. So patients are coming back for multiple injections, right? This isn't a one-time stop shot, right? So what's the schedule like, Dr. Chandra? How do the patients come through? Is it every 2 weeks, 3 weeks, month?
Yeah, that's a great question. So, initially when one is started, based on the trial that was done, as well as the current trials that are ongoing, the person receives kind of what I call a test dose of RP1 with Riad. And then 2 weeks later, they come back for, again, RP1, this time with the addition of nivolumab. And that is repeated every 2 weeks for 8 doses or 8 cycles. And then after that, potentially the RP1 totally falls off, and then it's just nivolumab once a month. But there is some verbiage where there can be some further discussion about perhaps re-adding the RP1 a little bit later down the road. And to, Riad, your earlier point of documentation, it's so key. I'm so glad you focused on it. I mean, site selection is a big deal. And I think we should be humble enough to say we don't quite understand the biology necessarily to figure out what is the best to select, right? Should we do a lymph node versus a liver versus a lung? We're not quite sure. And so I think the overall principle is we should rotate as much as we can. We should try to get that drug to be seen by as many of the melanoma tumors as we can in order for that to be successful, having clear documentation by our colleagues. And so intra-colleague and inter-colleague communication can be just clear and succinct and without any uncertainty. I think that's really key.
100% agree. I think it eliminates so many headaches, and we don't appreciate, an extra 5 seconds to be as specific as possible eliminates such a drag on the back end.
Let me add one thing to that too, Tyler, is that to what Sue was saying, this is also different from the IR perspective is because I'm very likely to upfront schedule the patient for several injections now. So she's a patient, he or she would be on the schedule today, in 2 weeks, in 4 weeks up front, right? So you're populating your schedule now, which is different. We don't have many treatments where we do that several times. I mean, oncology does that because of the cycles of therapy that people get, but this is new for us. So again, we're populating our schedule up front. It's all about being proactive and being prepared for that patient. But again, another part of the workflow that is the interventional radiology community as you practice IO have to adopt.
I like that. Now, they're going to get nivolumab at some point in the process of this cycle. And does Nivo have to be given on the day that they are injected? And because, for somebody who's traveling, that might be very convenient to have if they're traveling an hour, 2 hours to come see you guys, it might make sense to do it on the same day. But does it have to happen? Let's say they're local and waiting to do 2 visits might occupy an entire day. How does that work out?
Sure. I mean, ideally from the patient's perspective, I imagine most would love for it to be done all on the same day and then they can go home. But I think it is nice to be able to have a little bit of wiggle room there. So there's a 3-day window for these drugs to be given. So, if Riad injects them on a Tuesday, I can still inject them on that Wednesday and still be within the parameters of the trial.
Can I get back to technique with you for a second, Riad? Because what I've always strived to be, I want to do what Riad does when it comes to oncology. I want to do it. Okay. I want to do it the way that Riad does it. And I think a lot of us want to do it like Riad does. Can you go through the technique, the actual, because there's obviously not just putting a needle in and squirting the drug and getting out. How do you do Replimune injections? Walk me through your setup and process.
So in general, so you mentioned something interesting. So there is an actual injection protocol in terms of biohazard safety. All right. So that still has to be elucidated. I'm not going to spend much time on that because we're developing that with Replimune, but that will be part of the component. But from the technical component, once I'm ready sort of inject, in general, what I tend to do is I will advance into sort of the back area, the most, I'll get into a structure, go all the way to the back and inject as I pull back. Now, there are some discussions of maybe sort of spread it around a little bit. And then if the lesion is very large, I will certainly do that. I mean, I may sort of, if I have a very large 3, 4, 5 centimeter structure, if I can, fan the medication, across more territory, I will do that. But it'll also be limited. The natural inclination will be, oh my God, I have a large mass. Why not inject all 10 cc there? Because I clearly could. You don't want to do that. You want to distribute that. To Sue's point, you want to distribute it across multiple areas. And so in general, I think if you have 3 easy spots, you take that 10 cc. There is some guidance on volume. But again, if it's large enough, you can fan. Otherwise, I just go to the back and I start pulling back as I'm injecting. Pretty straightforward under ultrasound. The lung ones will have to be done under CT. That's a little bit different as well, as you might imagine, right? So you get into the lesion and probably towards the center of the lesion because you want to confirm that. You inject a little bit, you confirm with CT that nothing's moved, and you may have obviously less degrees of freedom unless you have a CT fluoro unit where you can sort of do some type of adjustment live while you're injecting. But in general, with CT, it's more fixed. But with ultrasound and a large lesion, you can potentially fan if it's large enough. Otherwise, I just go to the back and I start injecting as I'm pulling back.
Perfect. What kind of needle would you use?
Mostly I'm using 21 gauge needles.
Okay. So kind of like a micropuncture style needle.
Micropuncture, yeah, that's correct, yes. Yeah.
Okay.
I personally don't like the Chiba type with the stylet. I don't like those. They're too flimsy for me. I always like sort of the 21 gauge system that I can use, and I use it for obviously all types of punctures, livers, spleens, etc. So I'm used to that, and that's what I like to use. But some people like the styleted needles. They're a little too flimsy for me personally, particularly for large, deep lesions where there's going to be respiratory motion, etc. You need something a bit more of substance. So for me, my recommendation is micropuncture needle. As you know, the micropuncture needles are made short and long, and they also make, for the record, 20 centimeter, 21 gauge needles. Quick story, since we're in a podcast world, quick story is, the Cook makes those, and they had stopped manufacturing those, and I was not very happy with that. And I contacted them. I said, if you fire up the machine, quote unquote, I'll take 1,000 needles. Sure enough, they fired up the machine. I got my 1,000 needles, but there was a lot of demand, and so they keep making those. But so I recommend, there are long 21 gauge needles, and I think it's very helpful sometimes with larger patient population. Tyler.
Oh, brother. Yep. South Louisiana. Popeye's poisoning.
You said that, not me.
Yeah, I know it. We got those patients. I know all about the 20 centimeter, 21 gauge. Another thing about the technique, I would imagine that everybody wants to know your exact way of doing it. When you fan, do you come out of the lesion or do you stay in the lesion and try to redirect?
If I can stay in the lesion, I will stay in the lesion. The other thing I actually do with my 21 gauge needle, just so you know, is I actually put a curve on it. So then I can enter a lesion like this, and then I can just come back and redirect it without ever coming out. So I don't have to so all I need to do is twist it to get to fan it, as opposed to putting pressure at the initial puncture site at the skin, right? Because sometimes to fan, you actually need to come all the way back to get a different angle. But in this case, put an angle on it, so you advance your angle, then you just sort of twist it, and you can get a lot of territory.
Now, since you talked about bending the needle, do you bend on the bevel tip? Like, so you know how
at the end.
So, and do you bend? Does it matter which way? Like, so bevel up or bevel down? Do you bend a certain way so it cuts differently, or do you think about it?
I don't know that I've focused on that. It's a good point. Maybe I should look at that actually. But it's a liquid, right? So it doesn't really matter. But it might matter for a wire or something you're advancing. Actually, it's an interesting point. I don't think it matters too much for a liquid, but it's an interesting point. I think I'll have to take note of that and see what I'm doing.
The only reason I asked this, and I got to give props to Jim Milburn, one of our neurointerventionalists. When he was teaching me back injections as a resident, he always showed the bevel up, right? So the pointed end would be down. If you bend that way, the needle learns to cut. And so we would do these. We don't have skinny people in South Louisiana. We do, but they're not they're the minority. You have to learn how to bend needles. So he is a needle wizard. And I used to watch him. He would go Michael Jordan off the scoreboard kind of stuff. So that's cool. I like the bending the needle. I have personally not tried it for this, but I think that's what I'm going to start doing for this in the future.
I do it a lot. If there's a tough abscess to reach, to drain, I'll take an InRad needle and I'll bend it, because it's much easier to sort of go like this than to try to find some window that just doesn't work. So I do a lot. And at some point, as an IR, you have to triangulate in your head. I know the structure is there, so I got to get this way. It's really not that complicated.
Look, I love pulling pearls out of Riad, even when it's not even part of the talk. This is awesome. So when do you re-image a patient? They go through 8 cycles, right? Or eight biweekly injections. When do you re-image?
So, I mean, depending on how the trial is written, generally it's going to be somewhere in the 8 to 12 week range. I think in general, we see that these drugs, in general, they don't quite work overnight. It takes some time to harness the immune system. And so depending on how a particular trial is written, it's going to be along the 8 to 12 week mark is when we would reimage.
All right. What's coming down the road? So Ignite 3, you guys were doing that. What's coming down the pathway with intratumoral oncolytics?
Yeah, that's a great question. I mean, another one that's being studied that we are also doing at Northwestern, RP2. So RP2 is being studied in uveal melanoma. So all of this focus that we just went over has been primarily cutaneous melanoma. Uveal melanoma is a very rare subtype of melanoma. It occurs in the eye. That's where it starts, in the iris, ciliary body, or the choroid. And it has a high propensity to go to the liver. Like 80 to 90% of these, when they do develop metastatic disease, it tends to go to the liver. So RP2 has the similar features of RP1 that we've discussed, with an additional CTLA-4 engineered addition to it. And it's looking really promising in uveal melanoma. I think in general with oncolytic viruses, it's really shifting the paradigm a bit. In the past, intralesional didn't quite make too much sense for the vast majority of melanoma patients because they all come to us with visceral disease. Having a person just with cutaneous metastases or subcutaneous metastases is rare, right? And so we needed something for these patients with visceral disease. And, an intratumoral approach was really kind of unheard of. But now with this platform, it's really exciting. And even though melanoma is the poster child for immunotherapy in general, I mean, imagine the application of this type of an approach in other immunogenic cancers, such as lung cancer, kidney cancer, et cetera. So there's a lot of excitement.
15 years ago, it was melanoma. Immunotherapy was with melanoma, and then we talked about doing it in lung, and now we're in HCC. We're all over the place. So
right.
I imagine, and we'll probably see a much more rapid inclusion of other cancer types with something like this soon.
Agree. And, in hem-onc, Tyler, if I may, melanoma is often looked to kind of get a sense of what's coming down the pike, right? Because it's such an immunogenic disease. We're kind of in a unusual situation where we get to test and try these novel therapies, first and foremost many times. And then if it's successful, then it is, then evaluated in some of these other immunogenic histologies.
I do believe Replimune is getting studied in some other types of cancers, correct?
It is, but it's the furthest along in melanoma.
Perfect. Cool. Because I could see a potential application in HCC. I could see this, there's patients that have very aggressive disease and you could throw the kitchen sink at them. You can let Riad do the Y90. And, some people are just going to have progressive biology. And if you could do something to help kickstart and throw the kitchen sink at them, especially if it's well tolerated, it makes sense that might be, it's always worth a shot. What other kind of points would you guys have for someone picking this up? What kind of advice would you provide to interventional radiologists who would probably be the listenership or practices, oncology practices in general, or integrative interventional oncology practices in general? What kind of advice would you provide?
One thing I would say is cancer, advanced cancer management used to really be primarily under the purview of hem-onc. And now the exciting thing is that it is now truly multidisciplinary. I mean, these are advanced state patients where, in the past it was more like, oh, this is a hem-onc issue. Like we can't really do any local therapies to kind of help improve outcomes, but that's totally changed, right? So thinking of just hem-onc to treat cancer patients is archaic now. I mean, we really have to think with our colleagues, have multidisciplinary forums where we really, kind of can brainstorm and figure out when do we all get involved? What sequence should we be looking at these therapies? I mean, at the end of the day, I want to really expand the armamentarium for my patients, right? Just help them live longer. I may not be able to cure many of these patients, but what can I do to consistently, just constantly improve on their progression-free survival with each new agent? And so I think it's a really exciting time to be in oncology now in all the fields, including hem-onc as well as IR. We get to kind of offer these really novel therapies to these patients with very advanced disease.
For me, Tyler, a couple of things come to mind. One is just to close off the concept of the logistics. Just when you think about academic or community centers or private centers, you have to think about the prescription the RP1 prescription, who is doing that, the formulary, where is that coming, where is that being dispensed from, right? So there are some practical issues that depending on whether you're an academic center, community center, smaller private practice, oncology practices will have to figure out how to deal with the expense of the drugs, et cetera, right? So all of this stuff comes into play. There are some biohazard issues that occur that need to be further sort of elucidated as we create this protocol for Replimune. So there are some practical things. On a more human level, I would tell you this kind of program, it really is a partnership, but it is, for me, I like to think of it as a Batman and Robin, and I'm Robin in this one. I love being Robin in this one. That's part of the role, and it's part of when you get to work with Batmans like Sue. I think it just really broadens the scope of what IO does, to be honest with you. And again, it really is a call to arms that we have an opportunity to help these patients, a patient population we rarely address, frankly. We rarely address in IR, and so this really broadens what we do. And it's just a different way of interacting with our oncology colleagues, but all of us are part of the cancer center and this and that. And so this just adds to that armamentarium. And to Sue's point, this just adds to the toolbox for what we can provide for these patients. And it's a pleasure and honor to do all that stuff for these people.
I love it. It's a simple procedure with a very meaningful impact is what I see.
And Riad, I'm honored to be thought of as Batman, except
Batwoman, Batman, yeah.
I just don't have the costume. That's the problem.
I mean, now
work on that.
Problem.
We got to work on getting you the bat symbol across your chest so that you can wear it at your next podcast.
Won't tempt me. I will.
Next time we'll do it. We'll do a follow-up in a year, Sue and I, and we'll wear the costumes. That'd be pretty good, actually.
I hope I get to participate again. You guys are wonderful. You're very collaborative and collegial. This was fun. Thank you so much, Dr. Chandra and Dr. Salem. It's been another great episode on the BackTable podcast, and I look forward to catching up with you guys soon. I'm sure you're much more fun than Riad is, Dr. Chandra.
For sure.
So I hope to catch up with you sooner than him.
I would love that.
Thanks, guys.
Tyler.
Hey, thank you so much.
Thank you.
Bye-bye, guys.
Bye.
Thank you so much for listening. If you haven't already, make sure to subscribe and follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, or Blue Sky. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
and Ali Behetti.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandow.
Administrative support provided by Judy Dela Cruz.
Thanks again. See you next time.